Hi, my name is Peter. I'm an emergency physician working in Stockholm, originally from Denmark. And here today, I want to go through a trial that we just did a Journalclub on. It's called the PARAMEDIC-2 trial, and if you haven't lived under a foam rock, then you probably have heard about this. But I thought it was an important study to take up in our group, and I just wanted to go through the lecture here so it can be shared if anyone wants to listen in. It's called the PARAMEDIC-2 trial by Perkins, a randomized trial of epinephrine in and out of hospital cardiac arrests. The references for this, there's lots of foam references on this, and there's even a really good journal club done by EM Cases and a really good read through of the literature by First 10 EM. So check these out. And then there are some takes on how to do adrenaline after this PARAMEDIC-2 trial, and I'll come with my opinion on this as well. So for doing journal clubs, we would love to have some kind of formula so that we can continue using every time. And different people have different formulas, but usually it's somewhat like this. Before we head into our study, we need to do some kind of background reading to assess our pre-test probabilities. Because if we see the result of a study as as a test with a positive or negative likelihood ratio, then it makes sense that we need that, like, the way that that study informs our then knowledge of the literature and our decisions depends on where we come from probability wise. So we need to know where our pre-test probability lies, ballpark. So that's the first thing I'll go through here. The next thing I'll go through is the study itself, trying to assess what the likelihood ratio is, if it's a positive or negative study, and how trustworthy this study is, and so on. And then we'll go back to reality, and what does this mean? Where do we land, depending on whether we are skeptic, depending on where we land on our pretest probability. We may agree on the study results, but depending on our pretest probability, we may land on different post-test probabilities. So that's my formula for going through these. And I bet most of the journal club formulas are somewhat similar, the ones I've seen at least. But I like to do it in a probabilistic way, to use these just to take home the point that this as well can be used, it should probably be seen as a probabilistic exercise, where one study doesn't do anything for us, even if it's a really good study. It must be backed up by some pretest probability and so on. And if you want to know more about this way of doing journal clubbing and looking at the evidence of evidence-based medicine, then check out Anand Senti's EBM 2.0, his way of going through things. Also, I just wanted to highlight that when we look at a study, the things that we are interested in is the methods. This is where all the things are that we need. In the introduction, we can find why they're doing the study, and in the last sentence, we can see that what the question is for the study, what the study authors think is their question of why they're doing the study. But the methods is where we can dissect and see whether or not we believe this result, and then we go to the results section, and then we see whether or not what the result is, and from the methods we can see whether this is a trustworthy result or not. We can assess that somewhat, at least. All right, and I've already done a journal club on another thing before, the PRISM trial, but for doing more deep dive on how to do journal clubs and so on, I've done an introduction there, and you can go watch that if you want. Okay, so let's set the scene with the case for this PARAMEDIC-2 study. So a 69-year-old woman is found down with a witnessed out-of-hospital cardiac arrest, non-shockable rhythms ×4 before you arrive, and the downtime is 20 minutes. CPR has been provided from the start, and we're 5 minutes from the nearest hospital or center. So as a pre-hospital doctor, what are you going to do? Are you going to scoop and run, meaning go to the hospital for more advanced care, or are you going to take the time that it takes to put in an IV or an IO to give the adrenaline? That's the question here. And we can probably extrapolate this to what we do in the hospital once they arrive there. Should we continue to give adrenaline and so on? But that's an extrapolation. This study mainly focuses, on the pre-hospital care. Okay. So before heading in to the PARAMEDIC-2 study, we need to look at the background. And the background, which informs our pre-test probability, could consist of the studies so far. So the evidence, the bioplausibility, the mechanistics, is it likely that this will help? And the tangential fields, like today we're talking about adrenaline and the bioplausibility of adrenaline working in cardiac arrest to revive the heart and the brain. But the tangential fields may be, is there anything that actually works for this scenario? Are there any medications that have ever proven successful in this area? So that's some of the things that we could look at to inform our pre-test probability. So just a little bit of theory here, what we call epistemology. How do we know that we know something? Well, we could argue it from a mechanistic standpoint or bioplausibility standpoint. We could argue it from an experience standpoint, either our own experience, a non-systematic experience, or a more systematic experience, which we right now call evidence-based medicine as the model for, or the framework for this. There are other frameworks for systematic science and medicine, but we'll just not go any further and just say this is equal to evidence-based medicine today. And then there's tradition. How we've always done should always be done like this. And while these two segments are logical, there might sometimes be some truth to tradition, as some undiscovered evidence lies in tradition, or some unexplained mechanisms may lie in tradition, but oftentimes the tradition is not that is not a logical way of doing it, and it's usually a weaker argument. So looking at this study for the bioplausibility, so there are three, I guess, ways of looking at this. Either adrenaline harms the brain through vasospasm in cardiac arrest, out-of-hospital cardiac arrests, but it increases the cardiac survival. In such case, we will get more survivors, but most of them will have brain damage as a result of the adrenaline. Or we may have a scenario where adrenaline actually works for both the brain and the heart, in which case we will get more survivors, neurologically intact survivors as well. But there's also a bioplausibility argument to be made that it saves the heart in those who are already irreversibly damaged, in which case it's not harmful to the brain as in the first line here, but it's saving hearts and saving bodies where the brain is already damaged. So it's not the cause of the brain damage, but it's inadvertently creating more neuro damaged patients as a result. These are three arguments that could be made from a bioplausibility standpoint, but we do think like it is likely that from a plausibility standpoint that adrenaline, which works both as a kick to the heart but also as a vasoconstrictor, at least in depending on the doses, may help with perfusing the brain in all case scenarios, maybe except trauma. And so the bioplausibility it's plausible here. All right, and then moving on to the prior evidence informing our pretest probability. And the prior evidence is kind of summarized here by Justin Morgenstern, and also here by Justin Morgenstern and others, Justin Spiegel, I think, in this EM Cases podcast. So please check both of those out if you're interested in a more thorough work through of the evidence here. I'll just summarize what Justin Morgenstern says on his homepage. So there's 7 observational studies on adrenaline in out-of-hospital cardiac arrest. And the conclusion from all of those are that it increases ROSC, so the patient will have return of spontaneous circulation. But so far in these studies, no survival benefits or neurological benefits have been found. And the problem is that there's a high risk of selection bias in all observational studies and also these. So these are flawed studies and probably not the best method for studying this area. If you want to know more about how studies are biased and so on, what observational studies can and cannot do, then either check out my last Journalclub lecture where I went through some of these things, or check out people like Justin Morgenstern or Vinay Prasad, who goes through the do's and don'ts in these things for observational studies as well. Then there were 3 observational studies testing bundles, so not just adrenaline, but like the entire ACLS method in Canada. I think one of the bigger studies were, and the conclusion was the same as above. It increases ROSC, but it doesn't really do much else. Then there has been 4 double-blinded trials, and this is more tangential. It's not testing adrenaline per se, but it's testing the dosage. So they have done studies where they tried with 7 milligrams instead of the 1 milligram, and the conclusion there was, the summarized conclusion is, it doesn't help and it may actually hurt with higher doses. There's a signal of harm doing higher doses where there's less survival. And then there's one placebo randomized controlled trial with adrenaline versus placebo. That is Jacobs et al. From Western Australia. And it's not really called PARAMEDIC-1, but it probably should, because this is PARAMEDIC-2. This is the 1 if this is the 2, but it's just called the Jacobs study usually. And the Jacobs study had a high problem with getting the ambulances to actually do the study, because they believe that they wouldn't want to give their patients placebo, because they believed so much that the adrenaline actually worked, which is noble, but also one of the problems that we have with implementing things in medicine without studying them first. Then we have, like Vinay Prasad would say, the horses out of the barn. Once we have implemented this into guidelines, it's really hard to establish that we have equipoise. Even though we may say that academically, it's really hard on the ground to actually get that information, or get that through to everyone working. So in this study, they were just trying to do best by their patients, what they thought. And the thing is that when there's equipoise, we don't really know, right? So what they found was there's increase in ROSC, and likely an increased survival to discharge, but not statistically significant. And I have this the ciphers here. So there's a huge tail, right? The confidence interval does contain 1 here, but there's a huge tail, it's skewed towards positive. So you might have thought that if this was if there had been if they have done as they wanted to, then probably they had enrolled enough, and then it might have been positive. Okay. There has been a few systematic reviews, 2 systematic reviews, yeah, where the conclusion is the same. Increases ROSC, but not long-term survival. So this is where we stand before going into this. If you look at tangential fields, then there are some, like, which drugs do work in cardiac arrest. And there is calcium, that's like empiric calcium, that's harmful. There was a big Danish study that showed that, the COCA trial. And they did some subgroup analysis as well for hyperkalemia, and if I remember right, it didn't really show any benefit there either, but we still do give it, and I think we should still give it as it was a subgroup and so on, and it makes sense, and we have some experience that I've seen a few patients doing, like, anecdotal evidence that this actually works. So hyper-K is still a indication in the right dose. Remember that 10 milligrams of calcium chloride is the same as 30 milligrams of calcium gluconate. And we use calcium gluconate where I work, but the guidelines here say 10 milligrams of calcium gluconate, which would be a third of the dose that is usually recommended. So just important to give the right dose here. Okay. Vasopressin instead of adrenaline. There are some studies that do suggest that it's better than, like, maybe have an increased ROSC survival, but it's still the same, like, still no neurological intact survival and no long-term survival. Amiodarone or lidocaine for the struggle rhythms, there's a higher neurological intact survival if we do use those. That's why they're in the guidelines, but the evidence, as I understand it, is mixed and a bit weak as well, and they've never been compared to some of the more newer ideas from the dose VF study, where double defib is now the new thing in refractory shockable rhythms, right? Or an S model has also been before double defib. That was one of the kitchen sink things that we could do. And an empiric sodium bicarbonate in long-term cardiac arrest. It may be used there for empiric use because we think that the pH might benefit. It has never been shown to do any benefit, but it may improve the pH, like what you would call a lab-oriented outcome, a LU. And there's some signal that it may be harmful in pediatrics. So no benefit, and no benefit, maybe only a LU where it helps the pH. And it can be used sometimes in specific syndromes, like which I've stated here. So the tangential fields doesn't show that much promise. A little bit, but not that much. It is a hard field. It is a group of patients that are really, like, the sickest of all, right? They're dead if even if we do everything right, they often die. So it's really hard to prove that any of these therapies work. All right, so it is a hard thing to do here. But our bottom line is summarized by Justin Morgenstern like this. So using epinephrine results in higher rates, and I've inserted around ×2 rates of ROSC. Some studies say it's more. That's a conservative estimate probably. And more patients being admitted to hospital. It is unclear if more patients leave the hospital alive, but if they do, there is no increase in the truly important outcome of neurological intact survival. And we'll come back to this. Neurological intact survival is actually what we probably want, but there's some nuance to how we define that and so on. So this is before we head into our study. This is probably the best summarization of everything here. Higher ROSC, but nothing else. And we hope that the higher ROSC may go, like, may in hand, like if we get ROSC, then probably we'll get more survival if we just do everything right, and so on and so forth. So we hope that it translates to higher survival, and that in turn translates to higher neurological survival, but we don't know that. That's why we're doing this study. If we look at it from a probabilistic standpoint, for ROSC and survival discharge, I mean, ROSC especially that's probably a quite high pretest probability that this increases ROSC. Survival, though, maybe a bit lower if we wanted to part this one into a survival and a ROSC one, and the ROSC one would be probably pretest probability for adrenaline actually helping in ROSC is probably pretty high, but for it helping in survival is a bit lower. There's never been really proven here. For neurological intact survival, that's even further down the list, right? And you may have like the last group that in all of these studies, the adrenaline is given quite late in the scenario. So we're actually filtering for like the patients that do get ROSC before the paramedics arrive with adrenaline. Those are the patients that are excluded. So there might be a group where adrenaline actually works. These have not been studied, and we should probably, like the ones who just lost the pulse just in front of our eyes, we should probably not, by these studies, just say that they shouldn't get adrenaline, because we can actually not know that. So we're talking about a group that are a bit later in their cardiac arrest until the AMS arrives and can actually give adrenaline, right? So those are the patients that we might consider. These are the patients that are in this study that we're studying, and for those, the neurological intact survival is probably quite low, that it actually helps before. That's my interpretation. We could argue where it goes specifically, but that's kind of like how it is, I think. All right, so going into the trial itself, I usually do these 3 questions before any trial, inspired by a lot of these EBM gurus, among other Justin Morgenstern and Vinay Prasad. A lot of the studies it's not really about it's also about the analysis of the study, like the PICOs and everything that we're going into. But a lot of it is about what we think about the field and the study before going in. So these big questions are important, I think. What is especially when we're a clinician and not a scientist ourselves, we're a clinician trying to use this in our own practice. How does and we need to ask these questions before actually reading the method section. What is the question in the study that is trying to be answered, and is it what we actually need answered? Because there's also often a discrepancy here, that what they're actually trying to study is not exactly the answer that we are looking for. We're looking for a different question. Here they might be asking, what is the survival like, and we actually want to know what is the neurological intact survival like, right? So they may, but sometimes the questions are quite adjacent and they can be extrapolated to each other, but sometimes the questions are totally different, right? So this is an important question to ask before. Then it's, what do I do in my clinical work for this particular question? So it might be a great study and it's trustworthy and old, but if it's not what I practice, I don't have an MRI, emergency MRI for these patients. So this study doesn't apply to me, or I don't give the the pancreatitis patients 10 liters of fluid or whatever. So the waterfall trial doesn't really apply to me right now. So there's different, like, it's really important to sit down and think, how do I do this? How would I take care of this patient before going into this trial? And if it's kind of the same, or if it's very much the same, then the study applies to you and your patients. And then it's, what would an ideal study design look like? And it's important to think about that before going into the study, because then we can compare the ideal design to what they did. And if we can kind of compare those two, then we can see the mismatches between the ideal and what they did. And that's usually what we can, some of the main critique points, right? And we know that there's a huge difference between ideal and the real world. that's just life, right? So a lot of things in the real world has to be cut away from what would be ideal because of budgets or because of ethics or so on and so forth, right? And that's how it has to be. But sometimes they cut corners in ways that are not that good, that could have been done, and that's where we had to do very harsh critique on it. But this is hard, right? So hats off to all the people doing decent studies like this. Okay, so for the study one question, right? What they in paramedic wanted to ask is, in adult patients with out-of-house cardiac arrest, does the administration of epinephrine or adrenaline compared to a placebo improve survival? That's what their question is. And you can, for the study question, once you've done your PICOs, you can kind of go into more details in adults, patients over 16 years of age, with so and so. So you can detail it and nuance this. But this is like before going into the PICOs, this is the study question. What we actually want to know is neurological intact survival. So this is a secondary outcome of this study, as we'll know later on. But so that's one of the things. And the short answer to why neurological intact survival is not the primary outcome, that is because that would require a much larger study, as there's many more survivors than neurological intact survivors. Right, so it will require much higher numbers. What do? Right, we, at least where I work, is after the first non-shockable rhythm, 1 milligrams of IV adrenaline, and continues every 3 to 5 minutes. And the shockable rhythm, 1 milligram of IV adrenaline, 0.1 milligram, and that's 10 milliliters of that, so 1 milligram after third shock. And we follow the ERC guidelines. They say when adrenaline is used, it should be used as soon as possible when the cardiac arrest rhythm is non-shockable, right? So that's what they did in this study as well. We'll go to the PICOs for details, but that's what they did. And then the optimal design. For this, we would want a randomization, and of course a concealment of randomization as well, so you don't know which group you were allocated to. You want double blinding. You would want adrenaline from the start of the cardiac arrest, which may only be like possible in hospital cardiac arrests. And I haven't actually looked at that literature for adrenaline, but that might be of interest. Because one of the things here is that if we wait too long, then we are it's a selection bias, right? The ones who would have survived, they're survived. So we're left with this really, really sick group in this otherwise, and that's what they do in this study, right? So ideally we would have adrenaline before, but the real world doesn't work like that. We usually don't have everyone doesn't go around with an IO or an art line or a venous line, right? To give adrenaline in. So we need to know that if someone has a cardiac arrest just right in front of our eyes, we should probably not apply this study for that. Then there's differing dosing. Like ideally, that might have been a separate study, but we've only studied 7 milligrams instead of 1 milligram, and we only studied like higher doses. And that's I believe from some of the lectures I've seen on this, they say that it's animal studies on dogs, and that the lecturers, I've referenced the lectures here in the beginning, and some of the lecturers, they would say that these mongrel dogs are not, the dosage on them was 1 milligram. Why should it be 1 milligram in humans? So there might be, using that argument, it should be a higher maybe dose in humans. That doesn't seem to work, right? So it probably should be lower, if anything, if we want to test something else. But it's something I haven't seen studies on the lower dosage, right? So that might be a thing, but who knows? It's probably not that important of a thing. But I would like neurological outcome as a primary outcome. And maybe not using the MRS scale, or maybe using another kind of scale as along with the MRS scale. maybe the CPC or something else, something that has a better inter-rater reliability. Because this is one of the things in the entire stroke literature, that this is not a great inter-rater reliability, especially for the in-betweeners like MRS. I think it's 2 to 4. There's huge disagreement there, and variability. So that's probably how an optimal study design would, in my book, look like. That it's a double-blinded randomized controlled trial where you have a placebo. Everyone gets a bag of some, like a shot of something, and so on. So that we'll see if, and the optimal design in this study is, as we'll see, is quite close actually. Okay, now we go to the PICOs. So the PICOs, the population in the study, the inclusion criteria were above, or believed to be above, 16-year-old. It's hard to identify people once they're in the field, right, before they have the ID, but with out-of-hospital cardiac arrest, or OHCA, and there needed to be ALS-trained paramedics on scene so that they would follow the ERC guidelines, right? Exclusion criteria would be pregnancy, or believed to be pregnant, asthma and anaphylaxis, because we would like to, they should not be randomized to either placebo or adrenaline. That would be unethical because they need the adrenaline. Adrenaline before paramedics arrived, so those would be excluded, and that can be argued why that is. And then the traumatic cardiac arrests, and that's only 1 of 5 ambulance services that actually excluded those. So that's also important to think about. Probably should have been an exclusion criteria, because we would probably not give adrenaline to traumatic cardiac arrests anyway. But yeah. Adrenaline, what the intervention was, that was adrenaline 1 milligram of 0.1 milligrams per milliliter, and 10 milliliters of those equals 1 milligram every 3 to 5 minutes once commenced. As by standard, they used the ERC 2015, but that hasn't really changed in 2021. And the control was saline, same like drawing up and all, but and otherwise standard ERC care. And they, both of the groups, as I understand, went to hospitals, right? And you might think, well, different groups might get different treatment in different hospitals. Yes, but because of the randomization, probably they're treated equally. Okay, and then outcome is survival at 30 days. And we could argue whether this is a good primary outcome or not. It's not a bad outcome. We do care about survival. We just care more about neurological intact survival. And the secondary outcome is survival, different survival timestamps, different lengths of stay in the ICU, and the one that we probably would think is the most important, the neurological intact survival. And then I usually do the S. You can leave it out, but I think the study design is important. This is an RCT, it's a double-blinded RCT with 5 NHS ambulance services in the UK from 2014 to 2017. Good. All right, and this is the so this is the results. They enrolled 10,000 patients. Around 25% of those were excluded. 20 to 25% of those were excluded. A lot of them because they got adrenaline before. So 8,000 went on randomization, and so it's around 4,000 in each group, and there's a really low loss of follow-up, and then they were included in the analysis. So really, like, not a lot of loss, like not a lot of exclusions. That's good. Because they don't exclude everyone. It's not a really highly select group, and then no loss to follow up, and that's really like impressive in this field. Okay, so for the next results is the table 1, where we can see the results of the randomization, and we can just look down these to see whether first of all, does this group look like one of my patients? Which I usually see. If the average age was 20, then maybe this wasn't the same kind of patient group that I usually see. But I can see resemblance of my patients that I see with cardiac arrest at an age span of around 70 plus minus 15 years. That's probably quite right. And with different almost like 2/3 males, one third females, and so on. And the groups look quite equally, so there wasn't a lot of change. So the randomization is probably successful here. And on to the real results table, or not the real results table, but what we are kind of interested in here, right? So, so the primary outcome, and kudos to them putting it up in a good way, and with the primary outcome here, survival at 30 days. So one of the results is it's really a low survival rate, right? For non-shockable rhythms. In general, it is, but this is really low, even by normal standards, I think. And then you have the placebo here, and then you can see that over here they do the difference between these two and whether or not it's statistically significant. And you can see that if the confidence interval doesn't cross 1, then it's statistically significant, right? Right, and there might be some nuance with odds ratios, and different. It might be below 1, or it might be 1. You can comment on that. I can remember, but it's like from a probabilistic standpoint, it probably didn't matter that much, because it's still depends on where the tail is, right? So here, this is clearly statistically significant, right? Then the secondary outcome. And these should be primarily hypothesis generating, right? Because if you have a lot of secondary outcomes, then then one of them is bound to be positive. They don't have that many, I think. It could be much worse, but it's still our standards here are quite low because we are used to some, I guess, crabby studies on this, where you kind of p-hack and try to get your p results up and get positive results unethical, I think, but that's just how it works right now. All right, so but here I think they did a good job of doing this, and we look at the results, and we can see that, well, survival until hospital admission is very much positive, very much up. There's even besides statistical significance, we can see this is clearly more ROSC than, admission than the other, right? Survival until discharge, though, most of these die, right, until discharge. And then we have favorable neurological outcomes, right? So of these that do survive, 2.2% will have a good favorable neurological outcomes at discharge, and a few more will rehabilitate up to this point. All right. And here it's almost same picture here, right? But then, oh, sorry, I missed. Yeah, it was this one. Not many rehabilitate up actually, and here it goes down as well. So what we see here is this is a positive result, positive result, positive result. This is a negative result. It doesn't contain. It crosses 1, right? And here it also crosses 1. But this is a bit more. There's a tail here, right? So this is barely negative, I guess, when you look at it. All right. So this translates, and this is from the bottom line, this translates to a numbers needed to treat for survival, 30-day survival for numbers needed to treat of 112. So we need to treat 112 patients for 1 to survive at 30 days, 1 more, which has a fragility index of 6, which means 6 had to go from the placebo group to the epinephrine group, or vice versa, to change this result, right? So here it would be the epinephrine group to the placebo group. So it's quite a not fragile. It's not that fragile results, all things considered. And then it's important to think about this, like the neurological, what is neurological intact? Well, usually in most studies they would argue that is, if you have an MRS of 3, then you cannot wipe your own ass. That's usually what patients think are important, even though there's a lot of contra arguments about that as well. But they define good neurological outcomes as 3 or under, and usually in stroke studies, it's usually most of them is 2 or under. So this would make the result be even more like dismal. Here's just a paper in the PIC from another way of looking at it from the XGEM, link above here. And here's this graph, which is kind of the probably one of the center graphs in this study, right? Where the difference between MRS scores in the two groups. And Justin Morganson commented on this being a logistic scale. I didn't really get the point there, but in general, he thinks it's a bit misleading. But as I read it, it's like this is where they draw the line. They draw a line here at here, right? This is where they draw the line. So you can see that clearly there are more neurological intact people, neurological damaged people here compared to here, right? The ones that didn't, they just died here. That's probably what there's a bit more nuance to this, but that's probably how we would read this graph, and I think that's where Justin Morganson has his point from. I'll read this here for more nuance right away. But this, so what do we think about that, right? So on the look of it, that's not too good that we are actually creating more survivors with bad neurological status. So we're kind of, in harsh terms, creating more vegetables, right? But the nuance, I think, Justin Morganson, as I understand it, points out here. He says, if we take the numbers here at face value, and for a minute, then for every 1,000 out of hospital cardiac arrests, the use of epinephrine will result in 246 extra cases of ROSC, 158 extra admissions to hospital, and 8 extra survivors. So you see that. That's why we saw so many ROSCs but so little survival after 30 days, right? There was a huge dip there. Of those 8 extra survivors, 3 would have a good neurological outcome and 5 would have a bad neurological outcome. And those are the numbers, and I don't think we know what they mean actually. Are they? And I think that's why this is a bit misleading. Here it just seems like, most of them are just bad, right? Most of them are just having a bad neurological outcome. But in fact, 5 of them, we are creating 5 who have a good neurological outcome, and 3 will have a good, and 5 will have a bad. We are also creating 250 more admissions. 246. 246 more ROSCs, 150 more admissions. And the question is, which is a more societal and ethical thing, like, is this really what we want? Is this a good use of our resources? That's the more important, that's the bigger question here, right? But I'm going ahead of myself. I want to be able to know whether this result that we just said, is this trustworthy? That's the first, before actually thinking about perspective about this result. Is this even trustworthy? Can we trust this? And for that, we can use different things, among other this checklist from BEAM, Best Evidence in Emergency Medicine. And we can just go through this checklist, and the more check marks you have, the better it is, right? The more trustworthy, I guess, it is. There's no perfect standard. Sometimes one of these is so bad that it ruins the entire bunch, but oftentimes it depends, right? So it's a good way to think about all the more important methodological things that we need to consider. So the study population included is to focus on the ED. No, it's not focused on the ED. That's important to us from an ED perspective, but otherwise that doesn't really harm the quality. But it harms. It's something to think about when we extrapolate it to our condition. Is the patient adequately randomized? Yes, we say that. So we saw that table 1, and both groups were quite the same. Is randomization process conceals the patients and it's blinded? Yes, so they don't really know, like the one group got adrenaline, the other one got placebo, so no one knows which group they were allocated to, so that's good as well. The patients were analyzed in the group to which they were randomized. Yes. The study patients were recruited consecutively. We don't know really. We're not sure about this. They don't say anything about it in the study, from which I can see, and so I would say this is a maybe. I don't know. Sometimes you can check out the numbers. You can kind of calculate from, like, in the 3 years that this study ran, in 5 EMS or in EMS center, like EMS services, is it realistic that they would get around 10,000 patients? That's probably very likely. So it might have been really close to consecutive, right? The patients in both groups were similar in the respective prognostic factors. Yes, we saw that in table 1. All participants were unaware of group allocation. Yes, I think so. All groups were treated equally except for the intervention. Well, they were randomly treated in different hospitals, right? And that the randomization should kind of compensate for the potential difference in or variability in different hospital care. All right, so this should be yes as well because of randomization, I would say. Follow-up was complete. Well, it was very complete. There was a really well done job for loss of follow-up. All patient important outcomes were considered. Yes, they were. Everyone probably would have liked that neurological outcome was primary, but it wasn't. It was secondary. And yeah, it just requires a much bigger study, so it's probably wasn't realistic to do it. So that's probably why. So the treatment effect was large enough and precise enough to be clinically significant. Well, numbers needed to treat of 112. I don't know. That's what we need to discuss, right? But in general, this was a really good study, as you can see. It ticks a lot of the boxes, and mind you, a lot of the pharmaceutical sponsored trials also tick all the boxes. So this doesn't mean that all the boxes, that just because all the boxes are ticked doesn't mean it's a good study. It's about the questions that we asked in the beginning, the big 3 questions, like what are the doses of the like there's lots of nuance here, but this is just another data point to say, like, yeah, it's probably trustworthy study. They're in the internal validation of the study is probably quite good. Then the summary and the perspective, right? So lots of strengths and lots of lots of strengths in this study. It's the well done study. It's pragmatic. It's the best study to date, probably, besides effort-wise. It was probably just as good in the Western Australian study, the Jacobs trial, but this didn't have the same problems of staying on the protocol, right? So this is a better study from that perspective. Not that they didn't put in the work in the Jacob study either. So, but it was, both of these are really great. But this is from where we stand, a better study because it has a higher quality, right? It has limited loss of follow-up, is good internal validation, as we saw with the checklist. Okay, so what are the weaknesses? Well, yeah, we already talked about the questions we are interested in is primary outcomes, and I'm being a bit harsh here because survival is a good outcome, but neurological intact survival would be a better outcome. That is a weakness for it, but it's probably unrealistic to have that as an endpoint. Well, minor point is that they use the MRS scale altogether. I've critiqued that earlier in another lecture, and then they use it like usually it's MRS2 or below, and they use MRS3 or below, so the neurological intact survival is even worse. But as we saw in the table with the MRS scale, we can just look at it, and it didn't make much of a difference as I saw it. And then yeah, I don't know if it's a weakness either, but the survival is so dismal in this study. It's only 3% survival at 30 days, right? That's a really, really sick group, and it's really hard to know anything about this group. Like anything you do will probably hurt. Like they are already almost dead at 22 minutes post. 22 minutes, I keep mentioning, is the average time to which they gave adrenaline in these studies, right? So time to is quite late, and it's not a critique of the study, because they were really fast. I think the at scene arrival time is 6 minutes in average or something like that. It's really great, right? But what is the problem here is that we cannot extrapolate this for the patient lying right in front of us in the in-hospital setting, right? If they have a line, then we should probably just give adrenaline if we think they have a P or so on, or we can at least not use this study to inform us about that. Okay, so this is our pretest probability. Where do we go after this? Well, it is a survival-wise. This is a positive study, right? So survival-wise and ROSC, and so especially ROSC, but and survival-wise, this will increase our pretest probability or post probability quite a lot. Let's say survival-wise is probably here, right? Maybe, yeah. This is just arbitrary, right? But it's just around. I do believe that adrenaline will increase the rate of ROSC. I do believe that. And I do believe that the survival is slightly increased. Numbers needed to treat of 112 here. That it's believable. And it's a believable amount. The neurological intact survival was in this. It's a secondary outcome, so be cautious about that. But it's negative, right? There was a small tail. Maybe it's not 0. Sorry, maybe it's not 1, but it's maybe 1.5, something like that. So we don't really know whether this does anything to neurological intact survival. And now we kind of lost the equipoise as well, right? Now we lost the equipoise to do another study, because now it's hard for an ethics committee, now that it's been proven that it will increase survival. It's hard to do another study of a neurological intact survival, because if you're not giving anything that will help the patient survive, then I guess that's unethical. But we know that from this study as well that no one wants to be a vegetable, right? No one wants to survive just to survive, or very few wants to survive just to survive, right? So this is a mixed bag of feelings about this, because now we probably won't get that answer. Whether it actually increases neurological intact survival. And for the last one, we don't know, right? We really don't know whether we cannot use this study to inform us about the survival of the before 22 minutes, or the ones who were excluded, right? The ones who got ROSC or got adrenaline before EMS arrived. So, all right. This is just an illustration of, depending on where you lie on the spectrum before, I mean, even the most skeptic would probably would agree that this is a positive study, it's a well done study. the ROSC and the survival is increased with adrenaline. They're more prone to saying that, at least. And I am probably here that I think for survival it's probably higher, yeah. For the neurological survival, I put it in negative. That's not quite, it's probably not negative. It's just neutral. I wasn't that convinced about it before, and now I might be slightly more convinced because there was a tail, but it's still, it's kind of null. We don't really know. We don't really know. Okay, so back to the case, back to the reality now, because now we've done a background, now we've done everything in the study. Now we are coming to like perspectives. So what do we do with this patient? I mean, I know Justin Morgenstern in his blog, he kind of dances around this question, and he admits it to it in the comment section as well. For me, I think I'm convinced, or sorry, I'm still giving adrenaline the first couple of doses, right? Because those were excluded in this study, so they're not even tested here, and there's a bioplausibility that will work, especially if it's a pseudo PEA or a PEA, and it's not really a cardiac arrest. Then we know that's like they're in extreme shock. They need adrenaline, and it's probably survivable, and with neurological intact survival at that point. But at the point where it's 22 minutes, which is what they tested here, I don't know. It's really hard. This patient may be lost already, right? What can we do in the hospital? If the brain is already dead at this point, when we gave placebo, there was still like a dismal neurological intact survival. So should we call it a day? Should we stop at this point? This is just my thoughts about this. The protocol would say that we should we should probably move on, right? But when it comes to the questions, should we give adrenaline or not? Well, we probably should give adrenaline if we're thinking about just survival, and we are really, really optimistic about that the survival will have a carryover effect to the neurological intact survival, even though we cannot find it in this study. But my conclusion here is that, and the reason why I wanted to bring this to our students' attentions as well, is that once this patient arrives in the hospital, first of all, we look at the neurological intact survival. That's dismal. So that's important to know. We shouldn't be pessimistic, especially early on, but it's important to know what is the prognostic value of continuing CPR in this old person, or like youngish old person at this point, and it's quite low probably. We may be able to make them survive with adrenaline, but they're not going to survive. Like most of them are not going to survive until ICU discharge. And it's not a question I actually can answer here. What I know, I would just follow the protocol until it's changed in this scenario. I would though highlight that the medications are not that important as high quality CPR, as finding a reversible course and treating that. It's probably much more important, right? So it's all about opportunity cost. And if I don't have resources to do the adrenaline right now, then I would probably, I'll focus on other stuff. Numbers needed to treat of 112 is not good. It's not bad. There's lots of worse therapies that we use, but it's not good either. And you might think, it's a synergistic effect. We are testing this reductionistically, right? There's 112 here, and then maybe 100 here. Numbers needed to treat for different things, and so on, and it accumulates to a bigger effect. That might be so. It might be so, but there might also be harms, and the harms we clearly see here, I think, or semi-clearly at least, that we are creating more people with neurological who are neurological bad outcome or devastated, some would say. And it's worth noting whether we should continue this, but it's not a question for me. It's a higher question for the population of the societies that we work in. And I think they did an amazing thing here with the study. They asked some volunteers before, not the patients, but the volunteers who hadn't been. They put up scenarios for them and wanted them to rate three things that might be important: short-term heart survival, long-term survival in general, and long-term survival without brain damage. And it's clear that the most important thing for everyone, almost, more like 95%, like 95% or above here, is survival without brain damage. All right. So if we should take this at face value, we should not give the adrenaline. We should stop the CPR at that point. We should probably stop the CPR at that point, or we should give the adrenaline and then give it a chance, but really, really quickly. Once we see in the ICU that it's not going the right way, then we should, like, at which point we should stop, do end of life or end of care. Is also an open question. But the later, the more resource laborious this is. Right, and others might need that treatment, that ICU bed. Right, it's lots of ICU beds being taken for this. Right, that's worth thinking about, and this is probably the thing that, like, well, now that we don't have equipoise anymore for survival, meaning that we cannot do randomized controlled trials pre-hospitally anymore for this, then the question becomes this, like, qualitative studies about what the patient wants, right? And it seems like this talks is really clear language. So yeah, I have one of these articles that I really like from southern Denmark, where I grew up and used to work. Where one of our professors in emergency medicine, Mikkel Brabant, and his colleagues, Hanson, have made a good, like, qualitative study on what people think about their end of life, and it may not perfectly carry over to what we're talking about now, but I think, like, and there's always this, well, what they think now as opposed to what they think when they become sick and they're at life's end. Is not always matching, right? Or sometimes when you have a terrible disease and you survive it, but with, like, there are studies on paraplegic patients who their quality of life goes down, but then after a few years, I think it goes up to the same point or above what they had before. So you can survive diseases, even chronic and very devastating diseases. But what I think with the paraplegic studies is that they have an intact brain. These people do not have an intact brain. And so it might be different. All right, but here we're talking about, would I, like, and is all they ask elderly people on the end of life. I would say, if I should imagine not being able to take care of my own personal hygiene anymore, then I really don't know if I want to be here anymore. That's the MRS of 3. I don't hope that I end up needing help from any other people less than MRS of 3. I would like to end my life with some dignity. So quality of life for me would mean that you can live a good life and take care of yourself in a decent way. Also around 3, until you're not here anymore, but not that life should be prolonged in any way. I've said that many times that I still claim that I'm not going to walk again. If I'm not going to walk again, then I'd rather die. And this may be just said, like, this may be just before you actually get the disease. But yes, but there is a lot of truth to this. But if you are in a nursing home and become seriously ill, the care provider won't have the time to visit, and then you'll die alone anyway. Yeah, so it's important what I'm quite pessimistic this, but yeah. And all things considered about this life prolonging treatment and the accounts for the hospital as well, I don't wish this to be to prolong life. It's just a good life that comes to an end. Yeah. So my conclusion: adrenaline is probably most important early, first couple of doses, especially in pseudopedia and PEA or PEA. And of course anaphylaxis and asthma. Yeah. And adrenaline should not take high priority when arriving in the hospital. Instead, high quality CPR, defib, and the other things that we think, or either we know, or like if we're on this shockable rhythm thing, then we should do double defib here, right? If they've done three defibs and it didn't help, and then it's not adrenaline I will grab for, it's double defib right now. And then we should look at reversible causes. And we probably should think about ending, if it's a non-shockable rhythm, really like earlier than we think, oftentimes, especially if they're elderly in out of hospital cardiac arrests. All right. So that's it for now. And please check out the references, because I might have missed some nuances, I might have misspoken and so on. Please check out the references and take this up in your own group if you want, and at your own hospital. And yeah, I'll see you next time. Thanks.